Very good. Thank you very much, Sylvia. And again, welcome everyone. Thank you for joining us in this panel discussion. Today, we're gonna talk about some strategies and tips to create community partnerships when we are addressing housing and transportation as social determinants of health. And I want to start with some of the objectives. Please, if you can, next slide, please. Right, so our objectives for today are to describe how can we identify and establish community partnerships, as well as we're gonna have a discussion on how to implement these programs to meet the needs of the migratory and seasonal agricultural worker population. And our panelists will share some of the successes and challenges that health centers may encounter in the process of implementing partnerships and creating projects and initiatives towards addressing housing and transportation as SDOH. So I want to start very briefly to talk about who is NCFH. Next slide, please. So for those of you who don't know NCFH, we are a nonprofit organization located in Utah, Texas, just south from Austin. And our mission is to improve the health of farm worker families. And we do that by providing programs, trainings, and technical assistance, as well as resources for health centers, primary care associations, and any other farm worker advocates. We are very proud to be serving around 174 migrant and community health centers in our network to provide any primary care services to agricultural worker families. So then, jumping into our main topic, next slide, please. I want to give a brief background on housing and transportation as some of the main issues or main social determinants of health that are affecting the farm worker population. So as you can see there in the pictures, housing and transportation are one of the main or two of the main concerns when we are working towards improving health outcomes of farm workers. Adequate, affordable, and safe housing has been and continues to be a constant struggle for the migratory and seasonal agricultural workers, as well as transportation. And this is because of the nature of their work. They face many challenges and barriers towards accessing adequate housing and the lack of safe and constant transportation services in their areas. To move from home to work, but also to look for services to go to those healthcare facilities. And this has a big impact in many social factors which produce worse health outcomes for this population. So in terms of housing, we know that they have a different type of housing. For example, some employers may give housing to the ag workers, and there's a small percentage who use this housing provided by employers. And this is often the case for migratory workers, given that they travel for work. And this is traditionally met by growers, for example. They are the ones who provide this housing for workers because they travel so much. By the other hand, we have rentals. Farm workers often rent different type of housing. It could be houses, trailas, it could be small apartments. And nationally, we have seen that around 50% of the ag workers who come to the United States prefer to rent any property other than use any other housing methods. As well, they have other types of housing is private. Ag workers often own their private housing. They can invest in having their own houses, their own apartments, or their own trailas. And this is a smaller percentage of the farm workers. So private housing is something very important that we have to take in considerations because private housing is not subject to federal regulation. So therefore there might be housing units are not, it doesn't necessarily go through the federal standard requirements. So they might be exposed to more hazards and less healthy environments. And then we have seen also that some of the farm workers, a smaller percentage, in the absence of any housing options for them, they rely on sleeping in tents, some of them in cars, some of them in the open fields, or even in the farms where they work. On the other hand, talking about transportation, so mobility and long days of work often threaten the health of farm workers, and this poses a significant barrier to accessing healthcare because they don't have, they don't have the transportation methods to go to the clinics. They have, and especially those who live in rural areas, that they don't have bus service, public transportation services. So yeah, limited transportation options are very common in rural areas. Also, due to the COVID pandemic, there was a reduction in the methods of transportation. There were also less safe services in transportation. For example, the sanitary conditions were not guaranteed, so this increased the risk of getting COVID or infecting others with COVID-19. So as we can see, these two main barriers are something that we continue to address in health centers and other organizations to work towards improving farm workers' health outcomes. So it is very important then us as farm worker advocates to create new projects, to create new ideas, and how can we target this social needs. And we do this most of the time by creating partnerships with other organizations that might have similar missions and visions, and they want to work with similar projects as we do in our health centers. So for this topic about creating partnerships, we have two invited speakers today. From Generations Family Health Center, we have Judith Goddard, and from Sun River Health, Mark Santiago. If we can go to the next slide, please. Very good. So Judith Goddard is the System of Care Director. Judith has been with Generations Family Health Centers for over 20 years, starting as an office nurse and working up her current position. She has a passion for community health, and she enjoys working with disparate populations in efforts to improve health equity and overall health outcomes. Judith believes that all human first, and the serving of healthcare as a right and not as a privilege. We have also Mark Santiago. He is the Chief of Community Engagement of Sun River Health. A lifelong resident of the Hudson Valley, Mark has spent his career developing community outreach efforts aimed to improving healthcare outcomes for the underserved. And prior to joining Sun River Health, Mark served as a vice president on MVP Healthcare, where he was responsible for developing and expanding the health plan's publicly funded programs throughout New York State. So before moving to our discussion, we would like to give a couple of minutes to Judith and Mark to introduce their health centers and share with the audience who they are and what some of the projects that they have in their health centers. We can start with Mark if you would like to start.
Okay, sure. Thank you, Alexis. It's a pleasure to be here this afternoon to share who Sun River Health is and what we've been doing. As Alex said, my name is Mark Santiago. I've been at Sun River Health now going on 3 years. Prior to that, I worked for an insurance company. It was a Medicaid managed care plan in New York State. And I was responsible for developing the individual product lines of business, all geared towards government funded programs. Sun River Health is a not-for-profit community health plan, community health center that was started in 1975 by 4 African American women who were basically fed up with having to drive long distances to go get health care for their family. And they applied for funding, received the funding, and started the FQHC in a small town called Peekskill, New York, in Westchester County. Over the years, that vision has grown beyond Peekskill and encompassed the entire Hudson Valley, where we have health centers located throughout the Hudson Valley, and expanded into Long Island, where we began serving the folks in Suffolk County. And we developed, because we operated in Hudson Valley and in Suffolk County, we developed strong programs for the migrant communities there and the migrant farm worker communities there. And then most recently in 2018, we expanded into New York City, where we have roughly 12 health centers serving the neediest populations in New York City. We all together represent about 43 health centers throughout our service area. And it's a very diverse service area where it's very urban to very rural. And we provide primary care, behavioral health, all level of all lines of service in the healthcare field.
Thank you very much, Mark.
Mm-hmm.
Hi, I'm Judy Gaudet. Generations Family Health Center started out in 1984 as a little white house that had a doctor in the community who worked 2 afternoons a week providing free clinical services. And then they were awarded the federally qualified health center status. We went from that one little white house to where we are today, covering a 920 square mile service area. We have sites in Norwich, Willimantic, Danielson, and Putnam, Connecticut are our primary sites. 2 of them we have medical, dental, behavioral. The other 2 are just medical. We also have multiple school-based health centers and the across the Smiles Dental program. In addition to the regular medical, dental, behavioral services that everybody thinks of when they think of a community health center, we do a lot of wraparound services, and we have the migrant and seasonal farm worker health program. We do a healthcare to the homeless program. We have a Ryan White HIV program. We do a Hep C clinic. We have obviously many people who do the Affordable Care Act, and we have a total throughout the center of 31 community health workers that range in positions from care coordinator to outreach worker and care facilitator. So we're very excited about the opportunity to be able to talk with you and share with you some of the things that we do. And our areas primarily are suburban, but much of which is rural. So we meet a lot of challenges that some of the other health centers don't, because they're in their urban areas. They have more opportunity for community partners and services that perhaps our patients can't find.
Perfect. Thank you, Judith. So then let's move on to our main discussion, and we want to start with our first question. We can pass to the next slide, please. As we know, in fact, that housing and transportation realities around the United States depends many of the times of the availability and the access to resources. So I want to ask you both, what are some of the housing and transportation challenges among the ag worker populations in the areas your health centers provide services? Can you share some of the experiences with us?
So yeah, I can start. We have noticed as a part of the pandemic, more and more growers are no longer providing housing. And so that's forcing the workers to find their own accommodations. And accommodations or housing is sparse. Affordable housing is sparse in the counties where we operate, in both Suffolk and in the Hudson Valley. And so we're seeing workers that are, teaming up and getting, housing together, and they're very cramped multiple families and very small, but was designed as a one apartment dwelling, is housing, 2 families, sometimes 3, which, creates very unsanitary conditions and dangerous conditions, especially given the pandemic. And they're also now being, challenged by having to provide their own transportation to work. Some of the growers have, their trucks that they go and they'll pick them up, but others have require that they find their own transportation. So that's something that we've been noticing. It's definitely a trend.
Thank you, Mark.
Mm-hmm.
So some of the things we notice in our areas, many times when people think of Connecticut, I've heard more times than I can count that Connecticut is a very wealthy state. And that may be true in some neighborhoods, but it's definitely not true throughout the state. And that is actually where some of the housing issues come in, because there are, scattered affluent neighborhoods throughout some of the areas. So it skews what the median income might be. If you look up Willimantic, the median income is $35,000 if you look it up on the internet. However, 30.9% of our patients are living at or below the poverty level, which is $27,750 for a family of 4. And so what happens is, just like Mark said, they're living multiple families in one dwelling, which is, creating more health issues and more problems as a whole. And add to that the fact that a lot of our migrant workers that are brought in through the Department of Labor might be living in congregate and housing, et cetera, and they don't have any transportation to be able to get back and forth to appointments. The seasonal workers are living in a lot of rural areas where there are no bus transportation. So we have to be really creative in how we can try to address some of the needs for those individuals. And as a matter of fact, I do want to point out that 2 of the towns that we serve in our service area are amongst the top 8 poorest towns in the state of Connecticut.
So then, thank you very much, Judy. So then that moves us to our next question. We now see, what are the housing and transportation challenges in your areas. So I want to ask you, how do you assess your population needs related to social determinants of health, and what is the process of developing programs or initiatives to address these needs, like housing or transportation, for example?
So we utilize the Prepare tool developed by NAC, National Association of Community Health Centers. It's a survey tool that we review with our patients, and it identifies the various social determinant of health needs that a patient might have. So that's one method for identifying that. The other is, when you see patients missing appointments, right, routinely and regularly, especially around a given zip code. Those are ways of identifying potential areas where you might be able to begin a program to address it. One of the things that we were very fortunate of having was, we have a transportation team that provides transportation to some of our homeless patients in New York City, as well as in the Hudson Valley and Suffolk County. And we also have vans that we provide medical transportation for some of our farm workers, in particular in the Hudson Valley, where we will take them not just to see us, but also other specialty providers that are outside of our system. We will provide that transportation for them because our interest is their best health. So we've run those programs for many years and quite successfully. But as the pandemic hit, people were less willing to travel. Although we took every measure recommended by the CDC to keep our vehicles clean and sanitized, there was still lots of reluctance on behalf of the patient to get in a van, even with just the driver, never mind any other patients. So one of the things that we wanted to do was to utilize the video conferencing visits that were becoming so popular amongst other mainstream patients. And
you have some images, sorry that so you have some images. So Sylvia, if you can share the next slide. So Mark.
So this shows the results of the program over the last 3 years, where we noticed that there was very much a digital divide with this population. They didn't have access to the equipment or the technology needed to avail themselves of the telemedicine, telemedicine services. And so what we did was we brought the services to them. We spoke with local growers and with other homeless shelters that we were already working with, and said, listen, we're seeing that your clients are not coming for services, and they are very much in need of services. And we can meet those needs, but they just don't have the equipment to be able to do that. If we can drive our van with the mobile, with the, what we call the kiosk, right? It's actually just an iPad, right? If we could take that to you, then we'll even bring the internet service where we have our MiFi devices, and we'll help your patients to access this technology so that they can be seen by the doctor, and at the very least get their prescriptions renewed so that they can continue taking their medication. Or if they have other medical needs that can be done virtually, we can accommodate that. And so we were able to send our mobile units equipped with this proper equipment in some of the housing or the homeless shelters. We were also able to set aside, they were able to give us an office where we were able to put the kiosk, and the patients could schedule themselves ahead of time. We developed a schedule when we would be on site to provide that type of assistance. And these are the results. We were able to serve over from 2020 to 2022, we were able to serve 2,641 patients. 47% of those patients wound up joining one of our care management programs. So it was definitely needed. They had other needs. And of those, that represents 215 community partner locations where we installed these kiosks. And it equated to 413 kiosk events in total. If you can go to the next slide, I can talk a little bit more about this. Here are the overall results by month, the number of locations, the number of visits, the number of patients seen, and then second appointments that occurred as a result of this initial visit. And then the results of some of the care management work that we did. A lot of these patients wound up enrolling in our care management program, our health home program. So you can see it was definitely very successful in 2020. In 2021, as things opened up and people became more comfortable and started returning to the office, you see the numbers came down. And now you can see now in 2022, the numbers are very, very low. So it is still something that we would utilize in our mix of services that we incorporate to serve our community. But it's the importance of it or the rate of use is certainly declining, which is a good thing because these folks are connecting to care. And you can see that in the second to last column where confirmed second visits, you can see those numbers are pretty high, 933. Next slide. This is what the kiosk look like. You can see the visuals. Some of the things that we really need to do to make this successful is make sure that we have a private room where there's privacy, that we have staff on site to help people, that we promote it beforehand and get people to schedule their appointments. It's not a build it and they will come scenario. It's very much you have to promote it and get folks to understand we're going to be on site this day. Schedule your appointment and then be on site to help them connect. And what our workers do, our community health workers are out there They will help them make sure all the technology is working. Once it's up and running and the doctor is on screen and they're having the conversation, they exit the room for privacy, they have the conversation. If something happens, they lose connection or they lose audio, they'll go out of the room, call our community health worker back in to help them, and they'll help them to make sure that it's a successful engagement. And then we work very closely with our providers. We have providers that are dedicated to this the type of visit, this video visit, to make sure that there's access and availability for the patients. Next slide. And that was it.
Thank you very much, Mark. And definitely, yes, starting the pandemic, moving from having the patient in the clinic to then taking the clinic to the patients in their areas was definitely one of the main outcomes of the main strategies that many health centers did.
Mm-hmm.
Thank you very much for sharing that. Judith.
So at Generations, we do the social determinants of health assessments with every enrollment into our Farmworker health program, but also annually with all the rest of our patients as well. We do utilize prepared questions, but we also added custom questions, and we built the SDOH assessment into our EHR so that as our community health workers are engaging these individuals, we're able to assess the whole person. We've added things about, Department of Child and Family involvement, recent incarceration, any connection to the Department of Justice currently, things like that, because these are all factors that are going to contribute to whether or not they can be housed. And if they can be housed, is there a particular place that they can't go because of the, a legal history, et cetera. So we want to make sure we're getting all of that. And in 2021, we had 6,800 migrant and seasonal farm workers, family, and non-citizen friends that we worked with. And a good scope to measure it by is that of those 6,800 people, 3,320 of them described housing insecurity, 3,845 described financial strain, and 4,478 described that they had either lack of transportation or lack of access to public transportation. And these are all very, very significant when we're looking at how are we going to get individuals into healthcare. So Generations has for many years had a mobile program where we brought the care out to the shelters and the farms. But in the heart of the pandemic, the Department of Public Health wouldn't allow us to use the mobile resource unit that we were using because they were two small rooms contained within this we call it a van, but it's a very large truck. And so we couldn't bring the patients into those exam rooms because there wasn't, it wasn't the correct air and all of that. So we had to get more creative. What we did, understanding that the providers were also not seeing a lot of face-to-face patients, we went and purchased a very large number of track phones and data cards. And so we brought them out. We made sure that shelters and farms, et cetera, had them so that if they needed to contact the office or if they had a scheduled appointment, then the ag workers and the homeless population were able to connect. But in addition to that, we also gave them phones. So if we had somebody, let's say, who was chronic diabetic and needed more visits, we wanted to make sure they had that phone and they had the data cards so that they were consistently able to connect with their provider. Excuse me, I'm so sorry. We also made sure that we had bus tickets. Excuse me, we paid for cab rides, and we also purchased a large number of gas cards. So if they had somebody who could bring them, oh my goodness, I'm so sorry. Then they would be able to pay for that ride.
Great. So now that we know, you have identified what are the needs, you have assessed how, how many, what's the number of farm workers or patients who need this services. How can you then move on to identify those possible partners that you can establish connections with in order to improve, to create, or to plan projects like this, like the ones that you have mentioned, you have created in this, throughout the pandemic.
So for us, the first sources are existing patients, right? Identifying their needs through either the prepare tool or through their experience. So if we're seeing a large no-show rate or other things, it's kind of a good identifier. But we also, use Google. Google is our best friend, right? Doing searches for organizations, whether those that are providing housing or farms in the area. And then reaching out and speaking to them and saying, listen, what are the needs of your workers? What are the needs of your clients? If they have healthcare needs, where are they getting those needs met? And if they're not getting those needs met, we're a good partner for you. And then we begin to explain to them the services that we provide and what we can do. They them too want to see their constituents healthy and well served. And so they become a strong ally for us. And when we identify those strong allies, we absolutely come up with a memorandum of understanding to make it more official so that there's clarity about what it is that we're going to provide, but also so that they understand what their role is to promote this, because they are the trusted source here and will oftentimes be the voice that that the clients will listen to if they don't have a relationship with us already. And by doing it that way, they help to promote the services, to promote the programs. Like in case of the kiosk program, the shelters were ecstatic. The homeless shelters, especially those in New York City, where lots of them were abandoned by some of the providers that they had been working with. And when we came along with the kiosk idea, and if they didn't have the room for to give us a small office, we drove our mobile van there and parked it outside of the shelter, and had the kiosk on the van, and the clients were able to come out, and they promoted it to the population. We created flyers that they put up throughout the shelters, and it became a real lifesaver for them and for the clients themselves.
I think definitely identifying members of the community to help those us like advocates, health centers, providers is definitely a great strategy to to make that process easier and more efficient.
Mm-hmm.
I agree. I can say for us at Generations, we are very partner oriented. And so the best thing for us was we joined a health equities collaborative. We also are members on community care teams, which are groups of multiple resources and agencies that meet monthly and or weekly at the various locations. And there's a universal release so that we're able to talk about individuals and see, how can we work together and make the connection to get the services they need. We want to be cognizant of the fact that, there's a lot of nonprofit agencies, and, as a healthcare facility, there's things we do really, really well that, maybe a soup kitchen isn't able to do. But we also understand that when it comes to providing food resources or other things, that there's other agencies that are better suited to that. So if we work together and we partner and we share events, then we're able to meet all of the needs and wrap things up in a nice package without sending the individual, here and there, all over the place, trying to make the connections on their own. And I guess it's like working as a hub is probably the best way for me to put it. And by focusing on what we do best and referring for what others do best, then it streamlines the process and it allows us to help more people.
Definitely.
We also have the advantage of a healthcare system, a hospital system in our area who has a great community program, and they're going out to the soup kitchens and to the farms, and we're partnering together in that they're going out and doing screenings like A1Cs and bone scans and mammograms and things like that. And as they're doing all of these screenings, they're referring over to our community health workers, and then we're connecting them with the resources for primary care and other services that we can provide. And there have been a couple people who needed immediate attention. And so because we're on site working together, we were able to get those telehealth visits right then and there. And so the person's immediate needs were met, and then we're able to continue on for that follow-up care with that individual and or family as well.
Great. And these are great examples. Oh, go ahead, Mark.
I just wanted to add, I forgot to mention that, one of the things that we have what we call community outreach coordinators who are out there looking and prospecting other organizations that are meeting the social determinant of health needs of the community. And when we find a partner, we establish that MOU with them, but we also track the referrals that come back and forth. And we utilize a customer relationship management platform to do that. And it provides the agency with concrete data to let them know, wow, we truly are partners here. You've served, 15 of our constituents over the last month, and it also allows us to track it over time. So if we see increases or decreases, we can see what's going on, what's happening. Why is it increasing or why is it decreasing? And then it also, us as an organization, allows us to see which relationships, require the most attention, because some of them, they're great organizations, and they're meeting the needs of the community, but they really don't have that healthcare need. We're only seeing, some cases we get 0 referrals in a month. So by doing that, it allows us to really make the most of our staff resources.
Right. And these are great examples of how can we identify, what are the assets that our different partners have, and how can we meet the gaps that we may have, they may have, and then how could we merge our efforts to create partnerships and to improve these projects. So this takes me to our next question. As we know, there's always room for improvement. There's always room to evaluate our efforts, evaluate our projects. And I want to ask, could you share with the audience some of those challenges and success stories that your health centers have encountered throughout the process of implementing partnerships with other organizations?
Well, I think where it hasn't worked is where the goals weren't clear, where everyone felt good about the conversations, we felt good about each other's organization, but we really didn't have a clear objective in terms of what is this partnership, what is this relationship trying to accomplish. Whenever that exists, it usually doesn't work well. It's not as successful. But where we are clear with our goals and objectives, and where we align well in our goals and objectives, and we document them. That's why I was saying, that memorandum of understanding is very key. When we document them, then we know what we're working towards. So I would say that's probably the most important thing. Making sure that you're clear about what you're trying to achieve with your partnership, with your relationship, and identifying, making sure that that is something that can be identified, measured, and then work towards.
Great. Establishing goals and objectives. That's a great example of how can we start the right way in creating partnerships.
Absolutely, I agree. Establishing goals and objectives. In addition to that, I think it's really important to identify roles and responsibilities, because it's really hard to break down those walls when each agency is a little siloed and they, want to keep everything close to the vest because they're, obviously funding is an issue. They need to make sure that their reporting capabilities are up to par and that they're meeting the requirements, et cetera. So by partnering and establishing those goals and objectives, but also identifying those roles and responsibilities, it kind of draws a map of who's going to do what. And so they can visualize, you know, oh, they're not going to try and take our population from us or do what we're doing and duplicate efforts or take our funding. It's working together to make sure all of the needs are met. Understanding that we want to just support each other in our grant efforts and focus on really just taking care of the individual. So when it comes to challenges and key success, I do have a few slides. So next slide, please.
We can go next slide, one more slide, and then we can go back to that last.
Oh, I'm sorry. I think I got the wrong cue. For generations, with our SDOH assessments built into our system, we're able to run reports and supply information to community needs assessments or needs assessments for a grant application that we're applying for, et cetera. But what's even more is that we're able to share these numbers with community partners and say, you know, here's what we have for a need. How can we work together to meet that need? One of the things we work with, Connecticut is very, very lucky to have a 4CT program, and it's a not-for-profit organization that provides emergency funding via debit cards, and 100% of the money they receive is fundraised. So Generations is able to work with them, and it was really great, particularly during the pandemic, because especially non-citizen individuals who are not eligible for any of those benefits that everyone was getting, they too were out of work. They too were not able to pay rent, but they were not able to get any of the help that was being brought out through the CARES and the American Recovery, et cetera. So these cards, we were able to help people pay rent with a $900 debit card. We were able to help get them, you know, past the hump of not being able to pay utilities with a $300 debit card, or help them buy food, et cetera. What was really great is in the most recent iteration of this program, we were allotted a certain number of dollars, and inclusive in that, because now we want to bring people out of the pandemic, people who have lost jobs and are trying to get back on their feet. We're also able to utilize this card program to help pay for registration and insurance to get someone's car back on the road so they can get back and forth to work. We're able to pay for uniforms or books for a job training program. So it's understanding that there's a lot more to healthcare than just the, you know, face-to-face clinical service, that it's meeting the other needs. And if we have the opportunity to be a recipient of these grant funds, it's our job to make sure that we're connecting the people to what they need so that we can refer them out for other resources and make sure that all their needs are met. We also get a lot of donations through direct relief. So, you know, whatever they have to give as far as personal care items, et cetera, I'm always on board to ask for those. We get donations from other agencies or from community individuals. And so as you can see in some of the pictures in the bottom, we warehouse a lot of personal care items, but also glucometers and diabetic cookbooks, everything that they may need to try and remain healthy. Next slide. What I was talking about earlier, the track phones. So these are the track phones and the data cards that we purchased for individuals so that they could keep the phone and continue to do that telehealth visit. And for people who were not non-citizens and who were eligible for the Affordable Care Act Obama phone, once the 30-day card was up, we made sure within that 30 days that our CHWs were working with them to get them set up on SafeLink so that they had that ongoing phone connection and they didn't have to worry about paying for it. We also utilized the internet companies in our area who were providing that free internet and phone service for a lot of individuals. We purchased the blood pressure cuffs and pulse oximeters and Bluetooth scales, even exercise equipment, so that we could make sure that the people who were housebound or who, you know, couldn't get to appointments to do their blood pressures, et cetera, at least they could let the doctor know when the doctor was on the telehealth visit what their recorded blood pressures, et cetera, were. So while we might not get UDS credit for it, the doctor is better able to care for those individuals. Next slide. In bringing the the care to the individuals and addressing the transportation need, there's a lot of things that we had to talk about coming out of the pandemic. You know, who was going to get vaccinated and how were we going to get that done? So the farm owners were really, really gracious about letting us set up clinics on during the workday where we could just go in and get everybody vaccinated, not once but twice, because they had to have the 2 vaccines in most instances. And as you can see by the numbers here, the UDS number of ag workers that we had was 289 last fall. And of those 289, 285 received both vaccines. So I think it's a testament not only to our agency, but to the partnerships that we have in the community, as well as with the farm owners, in being able to vaccinate 98.5% of those ag workers last year.
These are great examples of success stories. And this takes me to our last question. What are some tips or strategies that you can share with the audience who are currently thinking on creating any kind of partnerships or are in the process of planning projects and initiatives to address housing and transportation barriers to the ag worker populations in their respective areas? What are some of those recommendations that you can give to them? Mark, you're muted.
Sorry. I believe, identifying the right partners is key, and ensuring that there's organizational support. You have to make sure your operational team, your clinical teams are all on the same page, looking at the same direction at the horizon, right? That's where we're headed. This is where we're going, because you're going to go there together. Sometimes organizations, the larger you get, the more siloed you are. And really, you need to break down those silos in order for these relationships to work well and to be successful. So that would be my recommendation.
Thank you very much.
For me, my biggest recommendation is always to get the buy-in from senior leadership and understand that the ROI, or the return on investment, is not always at the front end, it's at the back end. So when there's a lot of balking about, oh my God, it's going to cost too much money, or how are we going to afford to pay for these CHWs or this, that, and the next. And at the end of the day, the truth is, when you look at the back end and you talk about the improved lives and the quality outcomes that are achieved by having these types of programs, it's so important to the population we serve. Another thing is advocacy. Always advocating for change in systems, change in policies, change in many, many different things is extremely important. And one of a good example is in the state of Connecticut, Senate Bill 284 it is being pushed to ensure non-citizens through Medicaid. And in doing that, having them on Medicaid is going to allow them to be eligible for non-emergent medical transportation, which they are not currently. And that is going to help resolve, not completely, but a large portion of the issues of trying to get people in and out of care because of lack of transportation. And then there's just so many other programs that could be available if policies didn't eliminate a non-citizen person from being able to be eligible for these programs. And I think understanding those two things, buy-in from senior leadership and advocacy are two of the greatest ways that organizations can work together. And when you start leading a cause and being a grassroots effort, that encourages other agencies to join you and to want to be a part of something bigger and better. And for me, that's what partnerships are always about, because at the end of the day, it's about those that we serve.
These are great recommendations for our attendees to note down and have those when you are planning or when you are creating these projects. So then we're going to move on to our Q&A session. We want to open the space for anyone who has questions, or if you want to share some of your any recommendations that you may want to share with the rest of the audience. You can use the Q&A box, you can use the chat box, or if you would like to unmute yourself, please use the raise your hand function on the menu, and Sylvia can unmute you. So yes, you can write your questions in the chat or in the Q&A. Okay, we have one question. What methods do you use to hold community partners accountable for a closed loop referral?
I can take this one first if you like, Mark. We have become members of a platform called Unite Us, which is a community resources platform where you can actually make a referral online and track that referral. There's a release that comes with it, so you have consent from the individual to be able to share their information over the platform. And that way, not only can you track the referral that you've done, but you can also see if somebody else has done a similar referral or the same referral. You can send that consent along to other specialists or community resources so that there's not that walking back and forth from agency to agency to try and meet some of those needs. And it really streamlines things. What's really great about this platform is that you're also able to run reports. So every agency that is on the platform, whether you're working together on 10 people or one person or 10,000, you're able to run those reports and really see who am I getting the most referrals from? And that can guide you as for what grants do we need to look at or what partnerships do we need to build better so that we can continue to work on these things. And I'm not saying Unite Us has to be the platform to use. I will say, however, that in North Carolina, Unite Us was the platform that they used, and North Carolina is now being paid for community referrals and SDOH assessments and things like that by the state of North Carolina. So, and Unite Us are the ones who helped them set that up. So that is my goal for Connecticut, and that is how I want to be able to track and hold community partners accountable.
Thank you.
So referrals coming from partners to us, we can track that very well currently with the current CRM tool that we're using. We're able to provide the partners with reports. The only way to effectively do that is to insert our community outreach coordinator in that relationship. And when they have constituents that are in need of our services, that's who they reach. They reach out to the community outreach coordinator. He identifies where that person is coming from and is able to attribute that engagement with that particular partner. So it works well. Eventually, we want the clients to be able to reach out to our customer care center to schedule their own appointments. But for the first 3, in some cases 4 visits, we have our community outreach person be that point person for them. So that enables us to really track those referrals coming to us. For the referrals that we make to the organization, we have not been as successful. We too are looking at Unite Us. We're in the process of establishing a program with Unite Us so that we can make those bilateral referrals with our partners and ensure that the patients that we're referring to these external partners are actually availing themselves of the various services, whether it be a food pantry or a homeless shelter or what have you.
So that takes us to another question that Carrie shared with us. What are some examples of other organizations to partner with to find people in need?
So that's a great question. We have what we call referral channels. And I want to say we have about 12 or 13 different referral channels. It includes faith-based organizations, schools, daycare centers, adult centers, the housing, public housing, the list goes on and on. When we do our Google search, we search by those categories. And once we find the organization within our CRM, we classify our partners in those categories. So we know we have a good diversity of referral channels. That we're not just, you know, honing in on one aspect of the need. We're actually looking at making sure we address all of the community needs.
For us at Generations, we do a couple of different methods. First, we try to hire, if possible, the community health workers that have lived experience. We find that people with lived experience really understand the plight of the community that we're working with. In addition to that, you know, we use a lot of the same channels where, you know, we'll look up local agencies, et cetera, to work with. We work a lot with the interfaith ministries and the soup kitchens and the shelters. We also work a lot with mental health and substance use agencies so that we can, you know, identify. But in addition to that, we also do a lot of door knocking. So we'll go from agency to agency and hand out flyers that, hey, this is what we do. Can you share with me what you do? Is there any way we can partner? But we don't limit it to that. We'll do Chamber of Commerce, and, you know, we'll go to the local grocery store because by doing that, sometimes we get donations of grocery gift cards that we're able to utilize for our individuals. So we have a saying in my department that we're just gonna, you know, steal shamelessly, and not, you know, the real sense of the word steal, but that, you know, we're going to go over and we're going to share information, we're going to get information, and whatever information they can give us, we're going to incorporate that into what we do on a daily basis. And it's just, that's how we keep expanding our group. And as I said, we have 4 different primary locations in 4 completely different areas. And so we really need to be able to identify in those areas what's important, because the values in Willimantic, which is a very highly Hispanic population, is very, very different than the value in our most northeastern site, which is a lot of, you know, multi-generational old farmers. So it's, you know, we just have to be able to identify in each area what's going to work best for us and for them as well.
Very good. I think we have time for one more question. We have like 2 more minutes. So, and I think this question is for you, Judith. Do you find that your patient populations engage with the Unite Us platform? Sounds like you are looking for empowerment, self-service. Sounds like the next step. Can you talk about your vision there?
So I can say definitely it's all about self-service. We have care coordinators that will work with each individual as long or as short term as they need to. And we, you know, identify most of those as our highest risk patients, and they will set goals. We will talk with the individuals, what are you willing to try? What are you willing to do? By setting up those interventions based on what the patient need is, then we're able to kind of teach them what they need to know in being self-sufficient. We have the ability to let them work with RNs who can do education, or set them up with work programs. There's a lot of different partners that we use to try and get people back into the workforce who maybe can't do farm work anymore, or you know, who we set them up with some immigration specialists so that they can get their green cards and things like that, and not be fearful of getting assistance or you know, going out there and trying to be self-sufficient. So it's always about empowerment, but sometimes that doesn't work, and sometimes we need to work for multiple years with an individual, and that's okay too. The vision is definitely be there when they need us and help them walk on their 2 feet, and then if that doesn't work, be there when they come back.
Thank you very much. I think we have gotten to the end of the panel discussion. We want to thank Sun River Health and Generations Family Health Centers for being able to share that valuable information with the audience. So thank you very much.